Welcome to AETCM, the Emergency Medicine channel. Today let us discuss about sepsis management and newer guidelines in sepsis bundle. Sepsis bundle is a type of management or a sequence of management in emergency room. We will be discussing about sepsis management in emergency room. You know that sepsis is a syndrome wherein there will be an infection, that infection may lead to inflammation. That inflammation can sometimes trigger immune reactions. So immune reaction means body try to defeat the pathogen by antibodies. Sometimes that immune regulation can become dysregulated, that is immune dysregulation. That may produce problems in the blood vessels, that is microcirculatory dealignment, and ultimately that may lead to end organ dysfunction. So that is sepsis. Septic shock means patient develops sepsis and he develops vascular leak or vascular collapse due to vasodilatation. That requiring fluids. We can treat the patient with IV fluids like normal saline, lactate plasma, right? But patient's BP may not improve even after adequate fluid resuscitation. Then we may have to start vasopressors like noradrenaline to maintain the mean arterial pressure above 65. Then we can call the patient is having septic shock. So patient is having sepsis, inflammation, hypotension that requiring fluid and vasopressors to maintain the mean arterial pressure above 65. And patient also can have elevated lactate levels. Elevated lactate levels are actually due to, so here you can see lactate levels are elevated. It is due to the anaerobic metabolism because of the hypoperfusion status. The mortality in sepsis is very high, more than 10%. Mortality in septic shock is 40%. So these things we should remember. Now we should know why the patient develop vascular collapse. You can see here microcirculation, the blood vessels are there. Here you can see the blood vessels, and vascular leak occurs here. This area is like there will be pores that through that blood products, everything, components of blood, everything will come out. So slowly the amount of the intravascular volume will come down. So that is a major problem in septic shock, vascular collapse. Another important problem is vasoconstriction because of the infection, inflammation. Peripheral vasoconstriction will occur. Then what happens is the internal circulation will come down. There will be anaerobic metabolism activation that leads to lactic acidosis. So that acidosis also will be there. So this is a multi different types of problems occurring in the septic shock. Patient can have anaerobic metabolism, lactic acidosis, then patient can have vasoconstriction and vascular collapse due to volume loss through the micropores. So many problems are occurring here. So ultimately all these things will produce cell death. So reduced blood circulation to the cells and ultimately it will lead to dysfunction and cell death. One of the important parameter you can see in sepsis is lactate. We have already seen that why lactate is elevating in sepsis means because of the hypoperfusion, body will try to go to a state that is anaerobic metabolism to produce ATPs. So whenever aerobic metabolism is not taken place normally, body will go to another state that is anaerobic metabolism. Here the end product is lactate. So if the lactates are very high in the case of sepsis, that patient's internal circulation is not normal, adequate perfusion is not happening, and if the lactate levels are very high, more than 0.5, more than 5 or 4, sometimes patient can go to acidosis. This is called as lactic acidosis. Now septic shock, we have already seen that patient is having hypotension that requiring vasoactive substances like noradrenaline or norepinephrine or other drugs to maintain the mean arterial pressure more than 65. That is septic shock. Other parameters which can define septic shock are long capillary leak time, reduced urine output because kidneys are hypoperfused, metabolic acidosis, mostly lactic acidosis, elevated lactate that we have seen. These are the hypotension is the major component, but others also there. So hypotension alone will not satisfy the criteria for septic shock. Hypotension has to be there, and associated features also should be there. Like prolonged capillary refill time alone will not satisfy the criteria for septic shock. We need other criteria also, and you need this criteria also. Okay. So all these things, it's a clinical syndrome where all these components has to be there. Now there are some red flags in any other disease. Here also there are some red flags, like patient have high temperature or hypothermia, tachycardia, tachypnea, diminished beat pulse or abnormal capillary refill time more than 3 seconds, hypotension, low GCS, seizures, irritability, all these things, skin lesions like purpura or macular edema. All these things are red flags or danger signs in sepsis. So there are a lot of other signs like any infection like urinary tract infection. You have dysuria, fever, chills, pneumonia, cough, breathlessness, all these things. Cellulitis, red skin, tenderness, warm skin, all these things. So different types of clinical syndromes can also produce septic shock. So their findings also can be there in this type of patients. So depending on the infection, that sign also will be there. Now there is a parameter called as Q-SOFA screening system. Q-SOFA is Quick Sequential Organ Failure Assessment. Previously, Q-SOFA was one of the strong predictor for the mortality. More than 2 of these criteria are present, then there is a high-fold increase in hospital mortality. So nowadays, the recent guidelines say that it is not like that. You have to see other parameters along with Q-SOFA, then only we should make a mortality assessment. Q-SOFA alone will not satisfy for mortality criteria. So there is a major change from the previous guideline. But however, Q-SOFA is a very good tool in emergency room. But this should not be used as a single screening system to assess the mortality in sepsis. You have to add other findings also to that. Now, what actions you take when the patient comes to emergency room with sepsis? First of all, you have to recognize the sepsis. Then you have to recognize the shock, like hypotension is there, you have given fluids. Then only you can act. Okay, before that, when our sepsis patient comes to emergency room, we have to put 2 large bore IV cannulation, then start fluids within like immediately after getting the patient to ER, you have to start fluid. Simultaneously, you have to draw some blood samples for especially like blood culture, procalcitron and all. Blood cultures are very important. Blood culture, urine culture, chest X-ray, urine protein. All these things are very important to rule out infection. Procalcitron is one of the important sepsis marker. So that also can be done in emergency room. Most of the bacterial infection, especially gram-negative infection, procalcitron will be very high. Whereas in viral infection, it may not be elevated at all. So once you diagnose sepsis, put 2 large bore IV lines, start fluid resuscitation that we'll discuss afterwards. Then if the patient does not improve, go for vasoactive substances like noradrenaline. If even after then, if the patient is not improving, then you go for other parameters like steroid use and all that we'll discuss afterwards. Now, one of the important tools in emergency room where we can assess the patient's fluid status is ultrasound abdomen and ultrasound IVC. IVC can be collapsed when there is less fluid in the body. IVC can recover or increase size of IVC seen in volume overload. So IVC measurement or IVC collapsibility is an important finding in emergency room in volume loss, including conditions like sepsis. So any patient coming with sepsis, hypotension, if you are seeing the patient and you know that the IVC is completely full like this, you may not, this patient may not respond to your fluid resuscitation. That is very important. The hypotension may be due to some other reason like cardiac failure or something. Okay, so that is the importance of IVC evaluation in emergency. Now, volume resuscitation is very important in emergency room. Normally, in sepsis with hypotension, we always try to give 30 ml per kg body weight normal saline. That is very important. Normal saline is the ideal choice of fluid. Ringer lactate also can be used. That's one of the physiological or balanced solution. It can be used in almost all conditions except in severe liver failure. Plasmalogen is another fluid which is the most physiological fluid. It is better than ringer lactate and normal saline, but cost wise this is higher cost. Okay, so that is the only limitation. But most of the for all practical purposes, most of the conditions where you are treating in hypertension and emergency room, normal saline is the best choice. So 30 ml per kg is the dose of normal saline in most of the conditions. But remember, a patient who is having cardiac failure, liver failure, or kidney failure, patient may be already having volume overloaded situation. So much fluid in that type of patients can create problem. Especially patients who is having ARDS also, we should be very careful. This strategy is called as restrictive strategy of fluid resuscitation, whereas in the other strategy where we give large volume of fluid is called as liberal strategy. So when the patient is having the volume overload or ARDS, restrictive strategy will be better than liberal strategy. That is a change from the previous guidelines here. So according to this guideline, we have to give large volume in first 3 hours and continuously we have to give fluid. But restrictive strategy, we have to reduce the fluid intake, you have to monitor the patient, you have to auscultate the patient, bilateral basal preps, pulmonary edema, all these things are important. Another important fluid is albumin. They are colloids, the only colloid which can be used in sepsis. The albumin is very costly, but after initial resuscitation with your fluid, if you add albumin, that will be very useful because albumin has got a capacity to hold the fluid in the intravascular compartment. But the only limiting factor is it's very costly. And remember, most of the antibiotics bound with albumin is taken to the target sites. So that is also very important. So if patient can afford or if albumin is available, albumin is a very good choice. The limiting factor is the cost. So remember, according to your guideline, 30 ml per kg has got a weaker recommendation comparing with the previous recommendation, that is 30 ml per kg is a strong recommendation that has slightly reduced because of this restrictive resuscitation strategy. Now, empirical antibiotic in emergency room in sepsis. Previous guidelines say that you have to start the antibiotic in first hour, but here if the patient is not in shock, you can wait up to 3 hours and discuss with your seniors or your experts like ID experts. You can decide regarding the antibiotic within 3 hours. But if the patient is in shock, better to start the antibiotic in first hour itself. This is because of unnecessary escalation of antibiotic first day, or because of the wrong decision in the first day, unnecessary de-escalating the antibiotic. All these things can produce a resistance. So that's why this type of strategies are coming. So you can wait if the patient is not in an emergency. You can wait for 3 hours. Suppose the patient is in an emergency, start the antibiotic and decide on the antibiotic. But unnecessarily de-escalating the antibiotic may not be useful for any patient. Now, empiric therapy only if the patient is having pseudomonas or MRSA. If you are suspecting pseudomonas or MRSA, you need to have a wider coverage for this organism. Otherwise, above the diaphragm, most of the infections are gram positive. Below the diaphragm, most of the infections are gram negative. And depending on your antibiogram, antibiotic stewardship program, all these things, you can decide the antibiotic in your hospital. Whatever it is, we need to know where is the focus of infection, then only ideal antibiotic can be selected. Now, vasopressors, after starting the initial fluid, either 20 ml per kg, that is a restrictive strategy, or 30 ml per kg, that is a liberal strategy. That depending on the clinical scenario, we can start. If the patient does not improve with your initial fluid resuscitation, then you have to go for norepinephrine or noradrenaline at a dose of 0.1 to 1 microgram per kg per minute IV inhalation. Previously, it was told that we can start these drugs only through the central lines. But in an emergency, in emergency medicine, we will not have a central line. So initially we can start this drug on peripheral line. Very rarely peripheral line it can produce gangrene in the distal area, but nowadays the guideline says that you go for a proximal peripheral line so that this type of effects can be avoided. But however, noradrenaline can be started in emergency room after initial fluid resuscitation, even through peripheral line. That is the change from the previous guideline. But that peripheral line has to be more proximal to avoid complications of this drug. Next drug will be vasopressin. After initial noradrenaline, you can go for vasopressin. Then the next drug. Now another new drug has come. It is not available in our country. That is synthetic human angiotensin II. That is catecholamine resistant hypotension. We can add this drug 20 nanogram per kg per minute. IV continuous infusion can be given, but it is not available at present in our country. So we are not discussing that in detail. Now steroid use, if the patient does not improve with the initial vasopressin use, there will be some steroid deficiency in our body that may be producing this hypotension and vascular collapse. So we can start steroids, injection hydrocortisone 50 to 100 microgram QID, or it can be given as an infusion. Both are having similar effect. Oral tablets will not be working in acute conditions like patient is in sepsis. The absorption may be delayed. So IV is best. Whether you give IV bolus or infusion, both are same. There is no difference in the both strategy. So you can give hydrocortisone. Now there are some targets. There are no much change. Targets is the most important target we have already discussed. Mean artery pressure more than 65. Then next clinical target is 0.5 ml per kg of urine output. CBP more than 8 to 12 millimeter of mercury. Central venous oxygen saturation more than 70%. Then lactate clearance. One of the important measurement in emergency room, especially in sepsis with hypoperfusion, we have already seen that why lactate is elevated in sepsis. Internal organ hypoperfusion leads to anaerobic metabolism that produces lactate, that produces lactic acidosis. If you are resuscitating properly with your fluids, noradrenaline, slowly the lactate will come down. That lactate coming down is called as lactate clearance. If there is 10% decrease in the lactate clearance after 2 hours, is a very good sign for improvement. You can even add dobutamine along with your noradrenaline. That produces vasodilatation for internal organs. That also gives very good perfusion to the internal organs. But it may not improve the clinical scenario. It only improves the lactic acidosis part of the sepsis. But we are not targeting for that, so we are not discussing that here. So normally you treat the patient with fluid so that internal perfusion will increase. Then you can add norepinephrine or vasopressin. That also improves the internal circulation. Once the patient is improved, the systolic BP is above 100 millimeter of mercury, then you can even add dobutamine. That produces central vasodilatation. So internal organs get a very good circulation there and very good oxygenation. That also relieves the lactic acidosis. Now, once the patient is stabilized, you can even de-escalate the fluids and de-escalate the antibiotic. De-escalation of antibiotics has got lesser role in sepsis management nowadays because unnecessarily de-escalating the antibiotic can sometimes produce resistance. So, if the patient is improving with your initial antibiotic of choice, unless until you get a culture report, there is no need to de-escalate the antibiotic. But once the patient improves in clinical problem because of dehydration or vascular collapse, you can immediately de-escalate the fluid intake or fluid resuscitation. Otherwise, patient may go to volume overload, and that is not a good treatment strategy, especially in conditions like cardiac failure, liver failure, kidney failure, or ARDS. So, avoid volume overload in all these conditions. So, we have discussed one of the important topic, that is sepsis management and newer guidelines in 2021 last year guideline, which has got some changes from the previous guideline that we have discussed. The most important thing is the volume resuscitation. The amount of volume resuscitation is coming down. Like previously it was 30 ml per kg body weight. Slightly we have to restrict the fluid because patient is having, especially in patients who is having cardiac failure, liver failure, kidney failure, all these things. And antibiotic use, if If the patient is in sepsis alone, we can take up to 3 hours to decide what antibiotic can be started. If the patient is in shock, it is better to start the antibiotic within the first hour of the presentation to PD. Thank you.